Thank you, organizers, and welcome all panelists. So we'll begin with the case-wise discussion. So the first case is a 44-year-old male who presented with an incidental finding of a mass in upper pole of right kidney. When this mass was evaluated, this turns out to be a suspicious mass for RCC and found to be clear cell RCC on imaging. I mean, RCC, not clear cell, would come later. 2 lung metastases and 1 bone mets in the left femur. On further workup, how do you proceed? There are several options. You can bring in more options if you want to. One is a nephrectomy, metastatectomy plus minus SBRT to bone, pembrolizumab for 1 year, nephrectomy, IO plus IO plus wedge shift, TKI, consider surgery. So we can start with Anshul probably. Anshul, how do you proceed in such a patient?
So, he has limited number of mets, so I will go ahead with nephrectomy along with metastatectomy. Option
Okay.
number 1.
And what is the critical number you think is for metastatectomy?
Less than 5.
Less than 5. Is the site important?
The site is important, lung site, which we can do metastatectomy in lungs also and liver also.
And this patient had a bony metastasis as well. So does that change anything?
Coded SBRT.
SBRT, great. Any difference in the management from any of the panelists?
I think option one looks the best option here. Only duration of embryo should be give it for 1 year or longer. That would be a part of this issue.
Okay.
Because technically, you are SBRT to the bone lesion, and it is a curative dose, but still can be a part of this.
Sure.
So also IMDC, the risk stratification is also important, whether it is a favorable.
Say it's an intermediate risk. To begin with, the patient has presented with.
So both can be the option, the number 1 and number 4, because we have data of retrospective and observational study for number 1, but we have more concrete data for IO and TKI. So I'll prefer more with this IO and TKI combination. Maybe consider surgery if patient is having maybe symptomatic hematuria or pain in later phase of treatment.
So in that, in the keynote 564, I think they did not include the bony metastasis. That was, I think, one point that I wanted to bring on. If we go by the trial, they just had lung or liver that could be resected, but not bone. We can extrapolate, but if we go strictly by the trial criteria, M1 NAD patient did not include bone there. And it is a fair enough, I think IO plus VEGF TKI is a good consideration considering it's an intermediate risk. I think all the options are fair enough. Anything from other panelists that you want to add on?
Why not nephrectomy?
I wanted you guys to differ in your opinion so that my job is easy.
I think nephrectomy should be done.
Okay. Any points that... So I think we can take... you wanted to begin with systemic therapy. What's your hypothesis on that?
No, I just wanted to there are more concrete data regarding this combination, and we have not much data on upfront surgery. We know that carmine and certain
metastatic RCC, if a metastatectomy can be performed, I mean, the bony lesion is the only site where metastatectomy may not be possible, but practically it can be covered with an SBRT.
Yes.
So doing a resection upfront of both the metastases.
That's why I told that the 1st and 4th are okay, but I'll go with 4.
Benefit was more disease. So that is
agree. Bony was not taken, again, 1 point against that, but we can extrapolate that much. Right. A word about upfront cytoreductive nephrectomy. This data was presented in a large patient subset. Where do you fit in cytoreductive nephrectomy? This was a different case where it was an oligometastatic disease. But for routine patients in your clinic, how do you take cytoreductive nephrectomy? In all cases, selected cases, specifically this is upfront. I'm sorry for the spelling error. But specifically, this is upfront cytoreductive nephrectomy. Do you consider in all comers?
So for poor risk, it is no. For favorable and intermediate risk, if it is the bulk of disease is dominantly renal, when you see other sites, at that point of time, and most of the time it is systemic first, then you see response and then do.
So often cytoreductive nephrectomy has actually fallen after the Carmina trial. The paper itself mentioned that the use has gone to less than 1% in after Carmina was published. But no longer upfront cytoreductive nephrectomies are being performed in all comers for sure. A very selected subgroup, mainly I think a very limited burden of systemic disease is the patient that may be considered. And especially also if you look at this is real world practice, patients who had good PS, limited number of metastases, favorable risk disease. And more than favorable, I think without this categorization, it is more important to see the bulk that becomes a more important factor. The graphs would be similar if we divide these patients as such. Even without a nephrectomy, if this was a favorable group, this would fall there only. So this does not answer the question. It just says that we have moved on from that practice. Still, some patients would say. Coming on to the second case, this is a patient with multiple lung mets, multiple skeletal mets, a poor risk clear cell RCC, and treatment options. I think we have already discussed role of nephrectomy. All would agree that there is no role of nephrectomy. If anyone wants to differ on that, can specifically tell us. Otherwise, we can start again with from that side probably this time. That what is your treatment of choice here?
So mostly in my practice, sir, I start with IO with TKI and prefer pembrolizumab with axitinib.
Okay. We can listen to all the options first. I think then we can discuss how we to look at it.
Yes, sir. So majority of the patients will go for IO and TKI. And TKI would prefer along as per the tolerability. So mostly we'll give cabozantinib based, new with cabozantinib or pazopanib. We are not giving pazopanib.
Pazopanib we still
Yes.
don't have a...
And low dose IO and TKI we are giving for some patients who are not affordable. Though prices have come down, but still majority of patients are not affording. So in those patients, we are giving low dose Nivo plus cabozantinib. That also works better.
So this patient is likely to be symptomatic. So if it was not symptomatic, IO should be still considered, considering intermediate risk. Else IO
It was only a radiological finding with that burden of disease.
Yeah. So
The patient is still asymptomatic.
So
What
then,
would-
if it is asymptomatic, then IO can be considered, considering the
how
long-term
do you
data.
decide between the two combinations, an IO Nivo Epi combination or IO TKI, considering that Epi would be just 4 doses and then the quality of life remains good?
The most important thing is that long-term results or higher CR rates versus the risk of progression in first 2-3 months. So if symptomatic IO TKI, if not symptomatic, then can counsel for IO. Low dose IO TKI, I think there are
I think
data
is the
from
most commonly used regime in our setup at least.
we have data. I think CMC had one
CMC
paper where
present.
it was better than TKI alone, but not as good as full dose IO. But that helps.
That's fair enough. I think it's mainly finances that would bring on to that thing. So
Even we should see whether the brain mets are there or not.
okay,
So
no brain mets. and then-
cabozantinib has a better sinus penetration. So in a patient brain mets, I would use cabo plus nivo. So if it is not there, then if the patient is minimally symptomatic, as discussed, maybe IO combination. If we want a better responses, then Lenva Pembro and XC Pembro is a good option. XC is less toxic as compared to the Lenva. So
But in the number of CRs, if you look at in the Pembrolizumab was maximum. Although we should not be doing a cross-trial comparison, but numerically, if you look at all the combination of VEGF and IO, the numerically 16 or 18% was the CR rate in the Pembro trial.
it is all indirect comparison we are doing. So all
Risk
choices
group
are
was
equal, I
different.
think.
They had
All-
more good risk patients.
Wide valid choices. Anything can be chosen. So we have to select based on few factors only. In that case, these are the way we can select one.
How many of your patients would typically go on for an IO versus IO TKI? A rough proportion
I have
amongst
two patients. I have only 2 patients till now. Most of the
And-
patients IO plus.
IO plus TKI. Anshul?
So same IO plus TKI
Okay.
combination.
I think response rates is a critical component. When you're looking at response rates, a combination of IO and TKI would yield a response rate of somewhere between 50 to 70%, whereas the response rate with an IO would be somewhere around 30 to 40%. If you look at objective response rates, when the patient is typically symptomatic, you would want response rate. If the disease burden is high and the patient looks like it would become symptomatic, even then the preference would be an IO TKI. The advantages of IO is definite quality of life. The TKI impairs the quality of life a lot. And once you are done with that Nivo-EP period, Nivo goes on without any effect on the quality of life. And the long-term survivor is another point with Nivo-EP thing, the plateauing of the curve for almost around 20-25% of patients. These trials we discussed, now we are looking at long-term outcomes of these trials. Now, one question that comes into the mind is, what if the patient is a good risk metastatic? Combination of VEGF and IO or an IO even for a good risk. And does today's presentation or these trials long-term outcomes change your preference for even good risk RCC at this point? Dr. Anshul?
So for good risk, I can go with sunitinib also, single agent, or feasible then IO plus TKI.
IO plus TKI. What about IO and IO? Do you
No, not
consider any patient for IO and IO?
for good risk, no.
Definitely, Nivo-EP is no in good risk. IO plus TKI can be used. One thing is the sarcomatoid variant Nivo-EP versus that has to be also seen in history.
Sure. Rushabh?
One point for Nivo-EP is that with longer data, we have now overall survival benefit.
The curve that I wanted to show was, you look at favorite this is almost an overlap. Numerically, even they are similar, and even Surat is better sometimes. But if you look at this curve now, which is going for a favorable risk overall survival curve, seem that it is somewhere separating with a reasonable number at risk. I'm not reading at 96, even then it is 48. Now the median follow-up is almost 8 years. If you look at even those curves look to be separating, and these patients would also potentially be long-term survivors. So does that make a change in your thought process that even some of those good risk patients, some good risk patients have a higher risk of, higher disease burden, because the problem with the IMDC is that it does not typically include the disease burden into it. It's mostly based on your lab values and PS. So does that, Dr. Rushabh, maybe you can take these curves change your mind, or maybe look at
So at least this option comes into discussion, because otherwise traditionally we had thought that without TKI you treat favorable risk. Now, rather we can say that none of the IO TKI has shown overall survival benefit in this setting. Only IO has shown overall survival benefit. But with time, with longer follow-up, I don't know whether IO TKI will show that benefit or not. But if even if this shows the benefit, then continuing TKI for 6, 7, 8 years versus completing 2 years of treatment and getting that survival benefit is something which should be discussed now.
35, 40 years old chap in your OPD, and you're talking about potential cure kind of thing. And would you consider Nivo-EP in this specific good risk kind of patient? So it's not, we initially, I think, as Dr. Anshul clearly said, Nivo-EP is a no in a good risk patient. This is how we used to think earlier. But now with long-term survival, there are patients where you would, and you can potentially think even this combination, looking at quality of life and potential cure. So now we will see with all those combinations, longer term survival. This was, I think, the most interesting discussion for today, that with the addition of this, what was CBM 588, basically Clostridium and changing the gut microbiome and leading to better response rates. The numbers are too small, don't take this home. But very, very interesting and exciting data that we can almost improve the response rates, PFS, double, more than double. How do you think this would go into clinical practice? There are all other data as well where the usage of antibiotics previously, prior to the use of IO, also is associated with worse outcomes in many cancers. So quite interesting, although we can't take into practice. But any of you who's using any kind of a probiotic with immunotherapy at this point of time? No. So
Using.
Using?
It's an exciting data, not using it, yeah, but this is surely an exciting data.
I think numbers are too
uh, we have a more randomized control trial or better data. It's no harm in using it because it's a small intervention. It's not going to harm the patient, but if the patient gets more benefit, there is always welcome with such kind of intervention.
I think specifically for this, my thought is that we would need a specific India-centric study. One, because our microbiomes across the globe also vary in nature. So we may need our response rates and our probiotics may not exactly be the same. We'll have to see how
if it turns to be positive later on, we may miss few years of our patient.
Akhil did mention about the being these kind of things being manufactured by Indian pharma. So that would be pretty exciting to look at.
Yes, so one more point. Actually, at this time, we should see that we should avoid unnecessary antibiotic use. Because antibiotics
totally
disturb gut flora and that causes decreased response rates. And it is proven. So right now, we should avoid antibiotics. Rampant.
These were already presenting. So now the disease progressed after 16 months of VEGF IO combination, and there are multiple new liver lesions. These are the options: cabozantinib, IO, everolimus, exitinib, lenevro. This is, I think, a very, very variable practice that when it comes to second line, IO has been used and a relatively decent 16 months PFS has been achieved. And what are the factors that you take into account while choosing your appropriate second line for the patient?
So as I told sir, I usually start with IO with TKI combination. I have a patient from Bihar and took IO and TKI. At that time, I started with on avelumab and exitinib in 2020. Then patient remained disease-free for almost 15, 16 months. And then he progressed with liver metastasis, similar to this.
Exactly.
Yes. Then I started on this Nivo-IMP combination. Almost patient had a complete response rate, remains disease-free for almost 10 months. Now he is on third line lenvatinib and everolimus, and he's doing good.
Fair enough. I think this practice varies a lot. That is what we have seen, and we have data for almost everything in a smaller phase 2 trial. Or Cabo has some more data in the second line, but more or less, if IO has not been used in the first line, then we go about. But I would like to hear from all of you, what is your go-to regime after progression on IO VEGF combination?
It's similar, sir. If patient is having feasibility to continue IO combination, I will prefer.
So if the patient received Nivo Cabo, how comfortable would you be going to Nivo IP after that?
Yes, sir. So data is there. Some patients will respond still. So dual inhibition is having data, and patients might benefit. So we can try if patient is really fit. Otherwise,
does anything if this PFS was say 6 months, would your
that time I would
plan change?
That time I would think.
What would we keep seeing such patients, with a 6-month PFS or a...
So biology is very aggressive. In that case, obvious choice will be cabozantinib.
Cabozantinib. Would anyone add kind of anything?
It's similar. It is based on what TKI you used and the PFS you got with the first line treatment.
Same thing.
Everolimus, single agent for anyone?
Single agent not, if patient has not received, then
Anshul,
Same,
anything?
sir. Let my approval combination. I will prefer.
I think these are typical things that we take into account. What has been the PFS, where is the site of progression, what was used earlier. And then our practice is mostly within cabozantinib or Lenevro in second line, and IO typically goes to third line if the patient can take. Now, with that premise, are you happy with the design of this trial, the Light Spark trial, with the control arm being everolimus? Dr. Anshul? None of you did opt for a single agent everolimus when we were discussing. Maybe it was second line, but exposed to both VEGF and TKI, VEGF TKI as well as IO. So these patients were included in this trial who had received first line VEGF IO combination, and then second line they were eligible to be randomized in this trial. Would you be happy sending your patient into this trial, or you have concerns regarding the control arm?
Yes, sir. That is everolimus control arm is weaker, sir. To maybe we have to look some.
Maybe for the second line or third line, it'd be okay. But I don't know how you feel.
treatment of efficiency. That could have been a better arm. Treatment of efficiency.
Yeah, that would have been, I think, a better control arm, whatever, because the second, at this point, it would vary a lot, the practice as we discussed. So TPC would have been my choice in designing this trial. I wouldn't have chosen everolimus. Everolimus has been exploited in, I think, a lot of clinical trials in RCC at this space. In second line, it has been compared with everything. And it is mostly a glorified placebo that we have found with 2 to 3 months PFS benefit, PFS, and all other drugs have been winners against everolimus. So I was disappointed to see that. And it is not a previous trial. So I included that last line just to show you that this trial randomized between 20 and 22. It's a fairly recent trial. It's not a 2015-16 trial when we didn't have anything. So, but these things need to be taken into account. I mean, when we look at this, so prior lines of therapy, only 10 to 15% of patients were there who were like our patient, who were after first line combination. Most of the patients were actually after prior lines had received second 2 lines or 3 lines. Still, I mean, everolimus as a single agent is barely used. And also have a concern with the dose, 10 mg tolerance. I don't know how many of your patients tolerate that dose, even with DEXA gargles or whatever you use. And this again kind of makes me wonder. I would need help from a statistician that when you read the median PFS, if I'm not reading wrong, I checked it n number of times, that it is 5.6 months versus 5.6 months. At both the interim analysis, it's exactly the same in both the arms. If you analyze it in a different way, that when you look at 12 months, it becomes 33% versus 17%. That can happen because of differential censoring very easily in this graph. So if you read median PFS is exactly not even similar, it is the same, 5.6. How do you interpret this? Dr. Rushabh, we can start from you.
So most likely it is due to censoring, as you told. It is
more patients being censored in the benzodiazepine arm. So
if it was IO, we have a logic to say why it happened. But in
how does it change the bio? I mean, that also PFS same and OS different would make an IO comment. But here, graph is also the proportionality assumption is lost. I don't know, the full paper is not out. So I have a lot of concerns with this trial. Anyone who has an explanation to say, how is this significant? I don't know. I mean, apart from differential censoring, I do not have an answer to this. Or maybe who tend to respond for a very long time. That might be there. But unless we have that paper, it is very difficult to say what happens. Now, coming to the third scenario, the non-clear cell RCC space. How is your management different when it comes to clear cell versus non-clear cell? most of the times now we are seeing that similar agents are kind of picking up. But anything that you did differently with non-clear cell, we'll take comments from them, and then I think we can wind up. I had one more case for geriatric, but I think we can skip that. Just one comment from every one of you regarding management of non-clear cells, specifically papillary in this regard.
Initially it was similar, but now it's changing. So even for chromophobe, we have, the AKT pathway is more active. So everolimus best combination is better. I'm one patient of chromophobe RCC, taking Lenva since 18 months, still doing well, no progression. And we have just discussed data that Nivo EP is not working well. Even Nivo Cabo is not that good, as like Lenva is the best data which we have. I think
These are all single arm trials with that caveat.
But the data is very promising. The numbers are very good.
Even for, I would say that the OS, even with Nivo EP, reached 21 months. Nivo Cabo, again, impressive overall response rates. PFS was 13 months. But these kind of differences, 13, 14, 17, would be because of differential baseline population. So it is very difficult to compare. But one thing that comes up is a combination of VEGF TKI definitely looks more promising than a single agent this thing. So this, I think the slide was shown earlier. That is true, but we are reaching now N is equal to 93 in B61. So that was pretty good for a papillary thing. So what is your go-to regimen? I think Rushabh,
Pembrolizumab, except chromophobe where everolimus is something. And if patient is not affordable for IU, then Cabo more than is.
The Cabo did show an interesting data with the Peppermint trial, but this Cabosun 2, Cabosun 1 was intermediate and poor risk Cabo versus Sutent. But now Cabosun 2, the numbers are too small, I think, to take out anything. 32 patient RCT, anything can happen by chance. It is difficult, but I do agree that a combination of VEGF TKI does seem to be helping. So I think we can conclude our panel here. Thank you everyone for actively participating into this. Some of take-home messages that I took. CRN, I think we are now choosing our patients very wisely for CRN. Upfront CRN is typically for oligometastatic disease. Otherwise, some patients who are exceptional responders and have a bulk in disease and are symptomatic, that could be considered. First line, longer term follow-ups are coming, and favorable risk is one thing, one place where I am actually more interested to kind of think more whether an IU combination could be helpful in a particular subset of patients. Non-clear cell, we did discuss that a combination of IU VEGF, particularly Pembrolizumab in this case, does help. Easier administration of nivolumab, these people typically bring on when their patent is expiring. So nivolumab subcutaneous would come up. Geriatric population, I think we need more data, but most of us would be treating them with single agent TKIs or a combination of VEGF TKI with IO. Thank you once again. And I think we can take any questions if we have from. Thank you.
So the first line which you mentioned, no, cytoreductive nephrectomy and a question. I am from Mumbai, Dr. Bakshi. So what we do is, if we have an IMDC criteria 0 and 1 in the intermediate risk, we do see for cytoreductive nephrectomy. Secondly, the other thing which you mentioned initially was about Carmina. Now, Carmina has a lot of problems. Going a little forward to Checkmate 214, which was Nivo versus Sunitinib. And
214 was Nivo EP.
Okay, so there is some Checkmate which has Nivo versus Sunitinib. In that, there is around 80 to 85% nephrectomized patients.
All these trials are 80% nephrectomized by IOVEGF.
In that, Sunitinib did much better than the Carmina. It is about OS was 26.
Those were not randomized. So
maybe coming to cytoreductive again. So apart from the 0-1, where we do many times upfront cytoreductive.
So 0 does not reflect 0 IMDC can still have multiple lung mets and could be IMDC 0. So would you consider this here?
So I'll complete and then you
sure,
no problem.
No worries.
So the other big lot which we generally in MDTs discuss for CRNs are the ones which we have resectable metastasis as you discussed. or a solitary metastasis, we basically believe the biology may be better. For a whole lot of other patients, we give systemic therapies as you choose in the MDT. And then if they are amenable, we still consider for a CRN later. Those patients have done well in most of the studies. That's it.
So I would say I agree to certain of your points. IMDC, as we discussed, does not take into account the burden of systemic disease. So there would be patients with 0 and 1 IMDC with multiple lung mets, even liver mets could fall into that, multiple bone mets could fall into that, and still be IMDC 0 or 1. Such patients would typically require a systemic therapy first approach. And patients who are doing well, definitely, we also consider them for CRN at some point, but a very few patients. I think the trend that we saw, even with the timelines, that CRN was an essential part of the RCC treatment to begin with. And then only the next therapy was given. So that has, there is a paradigm change in that kind of.
No, absolutely. I added in the end that many times in today's treatment with IOs and IO-TKIs, we are it is about cytoreductive nephrectomy, the timing. If your patient is doing well, so please remember that. What happens is sometimes we leave that thought behind, the delayed ones.
Thank you. Thank you for your comment. Anything on that from the panelists? No. Thank you once again. Thank you, organizers. And I think if there are no other questions, we can wind up from here.
Thank you, sir, for the great panel discussion, and thank you to the panelists.